Okay, it's 12:01. Thank you, everybody. Please stay muted if you join us until question and answer periods. Welcome to the PAGNY Health and Research Foundation Grand Rounds Clinical Research Presentation Series. This is our first Grand Round for the year and the start of our new series. We are so excited to present poster presentations of runners-up from Research Day 2020. It was held on December 4th. And these wonderful, wonderful researchers didn't win the first prizes, but were very close. And we wanted them to have a chance to share their work with you. So next slide, please. This is, if you're looking for CMEs, this has a half credit. The activity sign-in code is 88DIEN. Make sure you sign in before noon tomorrow. You can either text to code 828-295-1144 or visit eeds.com. This will also work for other CME opportunities. If you're not a physician, you must go in and do the evaluation to receive the credit for the time, though. Any disclosures we have, Dr. Kelly and Dr. Shah have no relevant financial relationships to report in the last 12 months with a commercial interest. So this activity is not commercially supported. Next slide, please. So here we go. Our first presentation is the examination of the interpersonal theory of suicide and parental relationships in Latina adolescents at a visiting emergency department. The PI facility was Lincoln Hospital, and the first author was Flynn Kelly, and she is here today to present. Next slide. Wait for the video to start. Can't hear it.
They need to.
Okay. So I can speak, right?
Yeah.
Okay.
Yeah.
Is everyone able to hear it? I'm sorry.
No, nobody.
Confirmation.
Just for an introduction.
There it is. There it is. Thank you.
I will be presenting our longitudinal study titled Examination of the Interpersonal Theory of Suicide and Parental Relationships in Latina Adolescents. So just for an introduction and background, suicide is the second leading cause of death among adolescents. The National Youth Risk Behavior Surveillance Survey, disseminated in 2017 to high school students by the CDC, found that Latina girls in the US are at heightened risk for suicidal behavior as compared to their white peers. The same survey was again administered in 2019 and revealed that Latina adolescents reported more suicide attempts than white females. The interpersonal theory of suicide has received wide support in research as a tool developed to distinguish between ideators and attempters, mostly in adults. Here's a visual representation of that. So what the theory posits is that an individual holding two psychological states, thwarted belongingness and perceived burdensomeness, for a prolonged period of time will then develop a desire for suicide or suicidal ideation. These two components then combined with the third component called acquired capability means that they've reached a point where they've overcome the fear of their own death, and this would then lead to a lethal or a non-lethal suicide attempt. So all of these three components are required to produce this outcome. However, The few existing longitudinal studies within adolescent samples, mostly white, have only partially supported this theory. Overall, perceived burdensomeness has been found to be more consistent at predicting future suicidal ideation and attempts than thwarted belongingness. And to date, only one cross-sectional study, which is a qualitative study, has tested these constructs within a clinical sample of Latina girls. And this study also showed dubious support for the interpersonal theory, but the findings mostly aligned with what the previous longitudinal studies had found. So furthermore, among adolescents, parent-child relationships are especially relevant suicide-related factors and may influence the association between perceived burdensomeness, thwarted belongingness, and future suicidal behavior. One cross-sectional study with a mostly African-American adolescent clinical sample found that a combination of low family connectedness were high, and with high perceived burdensomeness were associated with SI. However, this study did not examine thwarted belongingness. Among Latina adolescents, parent-child relationship is an especially relevant suicide risk factor. So the current aims of this study, we wanted to examine how parent-child relationships influence the associations between perceived burdensomeness, thwarted belongingness, and suicidal ideation. And we hypothesized that the quality of the parent-child relationship would moderate the relationship between thwarted belongingness, perceived burdensomeness, and future severity of the suicidal ideation. So we recruited 49 Latina girls with recent SI from an emergency department and an outpatient clinic. Participants then completed a series of self-reports over 3 months. These included the Interpersonal Needs Questionnaire, which is a scale used to measure perceived scores would then indicate a greater presence of these two constructs. Examples of perceived burdensomeness are these days people in my life would be better off if I were gone, or these days in my life people would be happier without me. Thwarted belongingness would contain statements such as these days I feel like I belong. Secondly, we used the parent-child interaction questionnaire revised, and this was used to measure how adolescents perceive relationships with their primary parent or caregiver. This mainly deals with conflict resolution, and they include questions like, my father listens to me when I talk to him, or I often have a laugh with my mother. This was measured both during session 2 and at the 3-month follow-up. Finally, we have the Suicidal Ideation Questionnaire Junior, which was the instrument used to measure suicidal ideation. These included questions such as, in the past month, I thought about how I would kill myself, and in the past month, I thought killing myself would solve my problems. This was also administered during baseline and during the 3-month follow-up. So here are our correlation results. Lower thwarted belongingness and perceived burdensomeness were correlated with greater parent-child relationship quality, both cross-sectionally and at follow-up. But none of these variables that we looked at were correlated with the future severity of FI at follow-up. So we see an association with these variables, and that parent-child relationship is negatively correlated with both thwarted belongingness and perceived burdensomeness. In other words, the better relationship the child reported with her parent would mean that she would have less presence of these psychological constructs that are theoretically associated with suicidal ideation. So for the moderation, linear regression models showed that parent-child relationship did not moderate the association between thwarted belongingness, perceived burdensomeness, and future SI severity. In conclusion, future directions, the current study produced preliminary findings in relation to the restricted passage of time. Potentially significant interactions could reveal themselves with a larger sample size and greater lapse of time, and we intend to do this during the 12-month follow-up. Our future analysis will also include an additional variable to examine adverse peer relationships. So what these findings seem to suggest is that girls with lower perceived burdensomeness and thwarted belongingness are able to have more positive relationship with their parents for time. And we're thinking that the interactive effects of these variables on future severity of suicidal ideation will emerge with the longer assessments. So these results also seem to underscore the need for clinicians and mental health care workers to consider the importance of the quality of parental relationships as potential or risk factors when considering interventions for teens with suicidal ideation to effectively mitigate these thoughts and behaviors when considering treatments. Thank you.
Thank you, Flynn. Now it's time for questions and answers. Please feel free to ask Flynn any questions. You can unmute yourself, or you can chat a question into the chat box and I can read it off for you. So please. You did a great job, Flynn. No questions.
Thank you very much.
Okay. I have one question. Have you done this with other communities of color?
No, we have not done that yet, but that's part of one of our future directions is we're going to include the entire participant pool that we have collected so far, and then we're going to do some comparisons between different ethnicities. Yeah. That
will be very interesting. I mean, especially if you do like Black, Asian, and see how the differences are, you know. So. Yeah, we're very excited to examine those as well. So that is something that we are going to look at, and that should be done within the next month. So. Okay, great. Well, thank you very much. Next slide. All right. So this next presentation is clinical features, maternal and fetal outcomes in SARS-CoV-2 PCR positive pregnant women admitted to a New York City hospital in the Bronx. And the PI facility is Lincoln. And the first author is Dr. Vidya Menon. Presenter is Dr. Shah. Take it away, Dr. Shah.
Hi, everyone. My name is Dr. Shah, and I've been working with Dr. Menon as well as Dr. Timurthy for this project, which deals with, obviously, as she's mentioned, the features of maternal and fetal outcomes in the SARS-CoV-2 PCR pregnant women admitted to the New York City Hospital Lincoln during the time of the surge. Next slide, please.
Oh, have your slides? Sorry.
Oh, we don't. I can share my screen.
Yeah, please share your slides. Tiamara, will you let her?
Yes, I'm gonna make her.
Okay. So I'm not sure if anyone heard me, but as we know, the COVID-19 pandemic has resulted in many cases, many deaths among the population here in the United States, as well as globally. And in general, pregnant women are at higher risk for contracting several illnesses, lots of infections, just due to the state that pregnancy places them in. There's physiologic deviations that are associated with gestation, and immunologic changes as well that pose a very specific risk for this group of women. And studies have been published previously about the outcomes and effects of COVID-19 in various populations. However, the population of pregnant women contracting COVID-19 is limited so far. And so, we're just right now detailing the specific signs and symptoms among these patients and whether or not they are the same or different from the general population. So our goal was to basically establish a correlation between the infection and a cohort in regards to just general baseline characteristics, which for us included age, race, underlying medical conditions, if they had any, as well as like determining the classic signs and symptoms and admission findings, as well as outcomes. Because during this time, we also were trying to figure out what exactly were the, signs and symptoms of COVID in general. Was it GI? Was it neuro? Was it respiratory? There was like myriad of things that we were realizing were also related to COVID in terms of symptoms. In order to characterize these clinical features, we took a look at this very specific cohort during the peak, which began for us in March, and we took the data up until June. So what we did, as I mentioned, this is a retrospective study, and this was women admitted who tested positive on the PCR specifically from March to July. And what we did was we went through their charts, went through the records, H&Ps, as well as the lab results to determine these features. And what we did was we classified it with categorical and continuous variables. So basically we determined the race. So we saw that 75% of our population was Hispanic, 22 was African American, and 2.7 were of Asian descent. A lot of the women, actually 78%, did not have any symptoms at all of COVID-19 and were here, just for their obstetric and gestational conditions, whether or not they were here to induce labor, give birth, or for checkup for various other conditions. Of those who were symptomatic, 22%, 14% of those had confirmed pneumonia on X-ray, and 8.3% of the 22 required oxygen. We had 0 patients requiring mechanical ventilation and 0 reported deaths, which is quite significantly different from the CDC reports previously. 92% of our population were in their 3rd trimester, 5% in the 2nd, 3% in the 1st. And we also looked into the ways of delivery, of which 19 patients had vaginal deliveries, 9 had C-sections. There also were no fetal deaths reported. And during this time, if you recall, there was a lot of research going into potential treatments. So we had noted that 8 patients at that point had received azithromycin, 2 actually had received hydroxychloroquine, and 9 had received therapeutic anticoagulation. On the right side, you can see the breakdown in terms of age and medical comorbidities. We looked into a various number of them, but these were the ones that were present during our search into the baseline characteristics. 10 were obese, 3 had diabetes mellitus, 7 had hypertension, and 3 had a chronic lung disease. And the majority of our patients were in the 25 to 34 age group category. And on the left, I mentioned that we determined symptomatic versus asymptomatic. And while a majority of our patients were asymptomatic, those who presented with such symptoms, there is a breakdown here. And fever and cough were among the most notable symptoms, as well as muscle ache, shortness of breath, which we now have deduced to be, among the most common symptoms. We had a lot of GI symptoms as well. And interesting enough that we didn't have any anosmia in our population. As far as their clinical features determined by chart review, their mean hemoglobin was 11.5, absolute lymphocyte count, which in the beginning we were establishing that, lymphopenia and neutropenia may be linked to COVID-19, proved to be 1.71 in our population, which, aligns with that. Chest X-ray changes were notable in 5, as I had mentioned earlier. In terms of the oxygen requirements, I mentioned that we had 0 deaths, 0 vented patients, and 3 did require oxygen. I've gone into earlier the trimesters, which were most notably in their 3rd, and then the deliveries. What was important here for us is also determining the fetal outcomes and maternal outcomes. And that was, what we really wanted to focus on. So in terms of the maternal outcomes, we had a high 3 out of our population had chorioamnitis. And some of them had preterm labor, threatened labor, oligohydramnios and vaginal hemorrhage, and 1 with preeclampsia. And, these are all also risk and of just general gestation. However, in this population, we were trying to see if there was any association with the listed here with COVID-19, and if any of them were exacerbated or brought on by possible co-infection. In terms of fetal outcomes, we saw 2 had intrauterine growth restriction and 2 presented with fetal tachycardia. Like I mentioned, we had 0 deaths. So despite being in the epicenter here in New York, we did not see any extreme adverse outcomes in our patients during the surge of the pandemic, which is a really good thing for our population, obviously, but also this is different from a lot of the reports by the CDC and other places in the United States. And it's very interesting to see, in our population, why they did or did not have these adverse outcomes. And that's definitely something that should be looked into further. And while we had some symptomatic patients, the majority of these pregnant women were asymptomatic. So in that case, this is important because this proves a necessity of having a universal protocol to carry out testing for women admitted to the hospital. Now it is standard protocol when they're in the emergency room to have them tested, but at the time when we were doing this, we weren't really sure in what direction we were going. So having that universal protocol for women going into just delivery rooms, it was very important because they are often asymptomatic. And while, a few patients required oxygen, it's always something to keep in mind. And a significant portion of our patients had C-sections, which is similar to previous reports from New York City. And it's not necessarily entirely related to having this co-infection, but when you have the fetal outcomes, for example, the failed induction of labor, the fetal growth restriction, decreased movements, those things could be a reason to have those C-sections. And only 1 person in their 2nd trimester had required oxygen. And when this happened, the fetal outcomes were noticed to be in this patient in particular, the fetal movement, decreased fetal movement and tachycardia. So overall, as I mentioned, we need more studies to really understand if there is any increased risk with this COVID-19. Our population was small, but very fruitful in terms of evidence that there is a possible link here in increasing or exacerbating these possible outcomes that we don't wish to have in this population. And we need more evidence in regards to further research, because I think this is a field that has yet to be really explored. And we just hope to bring light to this area of research that is vastly uncharted. We also should have a lot more studies maybe in the fetal outcomes. There's a lot of acute intervention or acute screening, but there should be maybe long-term studies as well, which I hope to look into. But yeah, that's pretty much it. if anyone has any questions.
I do see one question here from Irene. Were the babies tested for antibodies?
In our studies, they were not tested, but I think it's a very good point, moving forward, whether or not if we were to continue to study this, that the babies should be tested, because I think it's very important for long-term, understanding of what the outcomes could be ultimately. So I think it's a good idea, but in this population, they were not tested.
You're muted.
Zane, I believe you're muted. Yeah,
Okay.
there we go.
Dr. Creighton, any association noted with IUGR over birth weight?
In our population, there was not, but I think, it's possible. We had a smaller cohort of only like 45 patients. And it's possible in a larger population, we would see these associations, but for us, no.
Great, thank you. Any other questions? Anybody would like to unmute or type in your question? Just giving everybody a second. Okay, wonderful. Well, thank you for joining us. Let me just reiterate that you can get a half credit CME by signing in to EADS at 88DIEN. I also want to remind you that we're having this weekly series, and January 13th, we'll be right back here. And our topics are impact of novel emergency department forward treatments area during New York City COVID-19 surge by Dr. Kambadi. And the second topic will be clinical findings post-hospital discharge in patients with COVID-19, telephone interview studies. The presenter will be Dr. Oliva. So we're really pleased that you joined us today. Thank you so much. Please fill out the evaluation so we know what you thought of today's program, how we can improve it, and for any further topics that you would like to hear about. Thanks so much, everybody.